Okay, as we wait for the for the respondents, I'm going to ask Julia Royal to sort of get herself ready to make her comments. You can sit down and comment from your seat. I'm the only one who's been told to stand up. Julia is an old dear friend. I first met her through Dr. Moore. And Dr. Moore, if you don't understand, he's like they say in the mafia, he's the thumb, he touches all the fingers. And so if you know Dr. Moore, you know a lot of people because he'll connect you. So Julia, she's a global health information specialist, but she's a lot more. She's helped in all parts of Africa, helped build health systems and helped bring knowledge to African institutions and make it accessible knowledge so that a journal article published in The Lancet is accessible to a physician in a remote area in the world, and more accessible that he doesn't have to actually try and figure out how to get that knowledge. So that's what she's doing now. But in the past where we worked together, she helped me establish the School of Public Health. She's one of the people that was an agent in that little experiment.
Today, I'm not going to talk about my work. I'm honored to present the thoughts and ideas of Professor Francis Omazwa, a foremost expert on health systems in Africa. He is CEO of the African Center for Global Health and Social Transformation in Uganda. He's the founding executive director of the Global Health Workforce Alliance and Director General in the Ministry of Health in the government of Uganda. As a medical doctor who once practiced in rural areas, he has walked the talk. From a Skype interview last week and his writings on the topic, I offer the following in Professor Omazwa's stead. Who can stop Ebola? What are we not doing right? What can we do better? These are the questions that are begging for answers from all of us. I can describe 3 categories of response from our experience in Uganda. 1, winning public trust. 2, engaging the communities. 3, using technology to identify, isolate, and treat the infected. The first 2 are of the highest priority and hold the key to stopping the current Ebola outbreak. They also constitute a long-term, sustainable solution to managing future Ebola outbreaks and to laying the foundations for strengthening health systems and attaining universal health coverage in these and other African countries. The government and ministries are very important. We need them as stewards to consolidate and coordinate the various actors. They are also institutions outside government that have potential in their own right. A strong government and strong NGOs working side by side can inform and inspire each other. Sierra Leone and Liberia showed us that health professionals there are few, often with less training and fewer skills. Their populations have little trust in the health system. The link and trust between the ruling class and the majority of the population is weak. If the government says one thing, the public does another. The disease started in communities and took too long to be noticed. The international community should have kicked in earlier, especially WHO. African governments gave their commitment at the African Health Ministers meeting, and they were among the first to go. Ugandan doctors, the Congolese Minister of Health himself went there with a team. White people in space suits terrified villagers. When the interventions were taken over by trusted local people, progress was made, but it's taken a long time. Here's what happened 15 years ago in Uganda, where people in communities trusted local professionals. We first heard about the outbreak in Gulu on October 8, 2000. The next day, October 9th, was Ugandan Independence Day, a public holiday. We still sent people to get blood specimens and engaged with the district. The next week, we visited with the Minister of Health and held a meeting with district and political community leaders. The internet wasn't yet strong, but we used it as much as possible. We got the local leaders and district and village health teams to be active and look for patients. Every day, there were reports from the Ministry of Health in the morning, lunchtime, and evening on the progress of the outbreak, reporting of new cases, as well as information on what to do. We set up call centers. WHO came with supplies, protective gear, and 3 to 4 people who had handled previous outbreaks. We sent our top people to live in Gulu, and the rest of the team visited weekly. At that time, there was no medical school yet in Gulu, but there were 2 hospitals. Around the 3rd or 4th week, the CDC brought a field lab so testing could be carried out on site with results available the same day. Prior to the CDC intervention, samples had to be sent from Gulu to South Africa. Local government structures need to be in place for teaching all individuals and households in rural and urban areas. These cells of government structures should be established with the full participation of the local people, and their leaders should know the communities well and be trusted by them. These cells should be linked to the higher echelons of the government and health system and be able to take action and transmit information both ways. These governance cells are present in Uganda and were effectively used for communication, confidence building, and case finding. Around 70 to 80% of sub-Saharan Africans live in rural areas, and governance structures of these communities are sometimes either non-existent or dormant. When government is absent, disease outbreaks occur, fester, fizzle out, or spread unnoticed. I describe this as embedding the health of the people in the routine governance of society. It is these local government leaders who can ensure that children are immunized, pregnant women attend antenatal clinics, that early marriages do not take place, pit latrines are in place, food security is assured, and law and order exist, enabling the communities to go about normal business and link with NGOs. This is the foundation of the health system and of universal health coverage that literally leaves no one behind. Actions along these lines are possibly already taking place in the worst Ebola-affected areas. I urge all key players to give this approach more consideration and resource investment. This time of crisis is the best time to produce or strengthen such government measures, and they are likely to last and be sustained in the future. I would also like to see more visibility in the media of the national and regional leadership from the affected countries, as this will strengthen their credibility among their own people, essential for the success of this approach. Finally, I wish to urge all other African countries to give this approach some serious consideration as we plan for our health systems and universal health coverage. It is a good time to be strategic in a genuine way, not just talk. Very often, organizations and institutions that would sustain interventions are passed over in favor of those not rooted in the country. Opportunities to engage are there, and the individuals and institutions to engage with exist in most African countries. Support from the international community can cultivate partnerships on various levels, from institutions to universities to the grassroots. Capacity building takes time and is best achieved through partnerships. We can learn from each other while working together in a poor system rather than our overfunded system, what can be achieved with far fewer resources. We have a huge young population. The quality of education needs to be strong on primary and secondary levels. We need to strengthen primary health systems. African governments ask for votes, saying they will address health problems, but they take their eyes off the ball. I would like to see global leaders engaging African leaders regarding what they are doing about health, education, the quality of the life of people. Many problems in the countries and globally have root cause in uneducated people, unsatisfied people. Africa is more stable, a lot more hopeful now than I have seen for a long time. The African Union is well positioned. There's strong movements on social justice, human rights, and gender. Economies are growing. In a reasonably short time, 30 years, Africa will be a different place if we do the right things now. Thanks. And I refer you to Professor Amazwa's chart for how this is all to happen, which is posted right over there by the door, as well as to this fabulous book that the Oxford University Press recently published of his called African Health Leaders, Making Change and Claiming the Future. And this is another report the Rockefeller Foundation supported of Professor Amazwa's work, Strong Ministries for Strong Health Systems.
Health disconnected from development is actually unsustainable. Absolutely. You can't actually have health and development without health. The liberty of a people can only grow if you actually grow that people economically. So it's with a lot of pleasure that I introduce Dr. Gloria Bozeman-Herndon, who brings the dismal science of economics to a different level in discussing the issues of development within the health sector. Dr. Bozeman-Herndon.
Good afternoon. I'm so happy to be here today. I have more than 45 years of experience in Africa. Tricked you all, huh? And I've served as a diplomat overseas for our Department of State. In fact, a part of my portfolio in 1975 when I was in Nigeria was healthcare. And I dare say things have not really changed that much since 1975 in terms of the administration of healthcare. And I think it's a dire situation. And as I have evolved, and as we have also all evolved, out of the diplomatic corps, I have gone into entrepreneurship. I've been in business. And I had, for over 20 years, one of the most successful minority-owned insurance companies. But things changed in the insurance industry. So I said, now that I'm in that other part of my life, I want to make a real difference. So I am the CEO of GB Group Global, and I'm going to talk to you today about one of our companies, GB Pharma Holdings. And you're going to be hearing a lot about this company for the next 10 years. In dealing with the challenges that face the pharmacy sector on the African continent, health security serves as a backdrop for all that we do at GB Pharma Holding. Firstly, what is most important to know is that most of the countries, about 60 to 80% of the pharmaceuticals imported are fake or substandard, mostly coming from, as Greg told you, India and China. Secondly, even if there are regulatory bodies in place to define standards, there aren't tools properly, and people are not properly trained to implement these policies. Thirdly, there isn't a local manufacturing of even the most essential generics. And lastly, innovative treatments are oftentimes overpriced, and people really cannot afford in the nations to get the needed medication. So our approach is to focus to provide accessible, holistic solutions for critical health issues. With a strong, healthy population, it is nearly impossible to be, without a strong, healthy population, it's impossible to be strategic in economic and development policies. Therefore, we with our partners, which include academic institutions like Howard University, Dr. Wuta, and current good manufacturing practices, pharmaceutical manufacturers, biotech companies like Immune Therapeutics, and other local pharmaceutical companies such as AHA Pharma, we're able to provide solutions of empowerment that move our agenda toward health security. Now, we're doing this in several ways. We're able to provide innovative and effective treatment protocols that address infectious and non-infectious diseases at affordable prices. And that's extremely important. It's got to be affordable. By providing these innovative and effective pharmaceutical solutions, we have two signature products. Number one, we have low-dose naltrexone, which is marketed in Africa under Lodonal. It is an immune modulator booster, which at $1 a day is proven in over 25 years of data from the U.S., Africa, and Europe to be effective in the treatment of HIV/AIDS, cancer, and a host of other disorders. We represent immune therapeutic all over Africa, and together with other partners like AHA Pharma, we have initiated a NAFDAC-approved 90-day bridging trial in Nigeria. 90 days, okay? You know, FDA sometimes does 11 years, 12. We have got it so far, and naltrexone is already approved by FDA, that we have a 90-day bridging trial in Nigeria for HIV. We have also been approved in Equatorial Guinea before the game, and and Malawi, and we are marketing also in other countries. Now that's one product. The second is iPure. Now, GB Pharma is a minority company that has a little bit of female influence. iPure products, that's a line of safe acid-based products that are effective in managing herpes, diabetes sores, acne, both on the rise all over the continent and here. The products are safe, and they're licensed with the pH 100 with the slash technologies, which is safe acid with the near zero pH environmental demonstrated safe for human and dermatological use. Over-the-counter FDA approval has been approved. It has gained a number of formulated products. We can use it for acne, skin care, hair care, antifungal products. But for us, one of the greatest things we're using it for is herpes, and that is really a pandemic right now all over the world. So it works against, I don't want to get into the science of it so much because then we can have a lot of complications with that. But there are the three products we're going to have, and they're going to be white labeled. Well, because I'm doing it, it's going to be black labeled. Is Zosta, and that is a product that's effective for, it's over the counter, and it's for herpes sores. The other second is Tarag, and that's trademarked, and it's for wounds, for diabetic wounds, as well as it contains also vitamin A, B6, calcium, and magnesium. Then we have pH Clear, which is an acne treatment. So these are three products you're going to be seeing in the marketplace. And when you see them and you see GB Pharma, you just say, you saw it first. You knew about it first. Another thing that we're doing, we're working on the development of current good manufacturing practices. We're establishing and working with many countries in Africa to establish manufacturing plants. We have been recently approved to assist in Equatorial Guinea to provide them with a manufacturing plant, as well as in Nigeria. And fourthly, we have been selected to work in Senegal to be the U.S. Trade Ambassador for the International Park, where we're going to have companies in the U.S. that are going to be manufacturing. And you know, I don't even have a whole minute. But what GB Pharma does is we work with partners, we come up with solutions, and we create outcomes. But the most important thing we do is we give back. So 20% of whatever we make in GB Pharma goes into an organization we have called GB Oncology and Imaging, and that is to work with the scourge of cancer that is on the rise in Africa. And we're going to be doing imaging services and serving people who are blighted with the diseases of cancer.
Dr. Julius Garvey is our next presenter, and I think my connection with him is the fact that I see myself as a revolutionary in the guise of the work that his father did. But he's going to talk to us about some of the surgical issues. He said yesterday in a short conversation I had with him that one of the commonest causes of death in Africa are injuries. They are on the rise. They are difficult to manage because it's actually very difficult to become a surgeon and to be able to fix people who've hurt themselves. I decided a long time ago I couldn't stand for hours on end with my hands in somebody's abdomen although I loved it, it was a difficult craft. And so he'll talk to us about those diseases that we don't think about that actually just kill so many more people, and the need to train people to manage that. Dr. Garvey.
I think training healthcare workers is really the key to the solution of the problem of healthcare in Africa. Sub-Saharan Africa is the poorest region in the world and has the greatest health problems. It has 10% of the world's population and 24% of the world's disease burden, but only 3% of the world's healthcare workers and 1% of the world's healthcare expenditure to address the problem. Mainly contributing to the disease burden is HIV/AIDS, malaria, and tuberculosis, as well as communicable diseases such as pneumonia, meningitis, cholera, Ebola, diarrhea, measles, and neglected tropical diseases. There is increasing death and disability from non-communicable diseases such as hypertension, diabetes, stroke, cancer, and chronic respiratory illnesses, which we know quite well here. Women and children bear a disproportionate share of Africa's heavy disease burden, with 4.8 million children dying annually, mostly from pneumonia, diarrhea, malaria, and measles, easily prevented with a few basic interventions: clean water, proper sanitation and hygiene, adequate nutrition, oral rehydration, immunization, and insecticide-treated bed nets. Roughly 1 in 20 women will die of a condition related to pregnancy and childbirth. Again, a small set of interventions would deal with such much of the problem. Access to primary care, antenatal care, attended deliveries by skilled birth attendants, postpartum care, and access to emergency obstetric care for difficulty and complicated deliveries. We've already mentioned the high toll of accidents and trauma in the young population. Africa's brain drain partially accounts for the paucity of health workers. Estimates in 2008 indicate that about 135,000 doctors and nurses who were first trained in sub-Saharan Africa are now living and working in Western countries. Estimates from the UN suggest that this export of skilled professionals, not just from the health sector, but other sectors, cost the continent around $4 billion a year, and that each migrating professional costs the country about $184,000. This means that the cost of the loss of 135,000 doctors and nurses amounted to approximately $24 billion. Now this, plus the poorly compensated extraction of natural resources, is what keeps Africa poor. And of course, we could go on a lot about world trade and the things that the World Bank and the IMF have done in terms of their conditionalities, in terms of reducing budgets in the area of healthcare and education. Poverty manifests as dirty water, poor nutrition, low levels of education, poor hygiene and sanitation, environmental degradation, inadequate housing, and employment. Health problems are magnified and reinforced by these factors, so that a vicious cycle develops in which poverty and its determinants increase the burden of disease, while ill health contributes to poverty. So investment in health is therefore basic to sustainable economic development. Health is a multi-sector problem, and budgets have to be adjusted accordingly. If every African doctor and nurse who migrated were to return home today, it would only solve approximately 10% of the problem. So the brain drain is not the problem. The World Health Report estimates, at least not primarily the problem, the World Health Report estimates that 1.5 million more health workers are needed to reach minimum standards that would allow MDG's Millennium Development Goals 4 and 5 to be reached. That has to do with maternal mortality and child and neonatal mortality. Clearly, many more healthcare workers need to be trained, and they need to be trained locally. Doctors, nurses, other clinical and technical staff, as well as managerial, administrative, maintenance, and logistical staff are needed to keep a national health system going. One of the things that I suggest, and the direction in which I move, has to do with the training of healthcare workers to meet the problem. And the problem is approximately 70% of the population in most African countries, the sub-Saharan African countries, live in rural villages and communities and bear the brunt of the disease burden, complicated by lack of electricity and inadequate transportation to get to major hospitals. The system, therefore, needs to be equitable and decentralized. Much of the disease, death, and disability extent is preventable, and appropriate knowledge, clean water, addition of micronutrients to food, protection from mosquitoes, and a small range of drugs would make a huge, significant difference. A practical approach to health improvement would therefore focus on primary care and prevention, working across sectors with people in their own communities, rather than treating disease in late stages at distant hospitals. If we use in Africa the Western model of scientific medicine developed in the 19th and 20th centuries, where good health care is based on doctors, hospitals, and highly complex technical procedures, Africa will never catch up and meet its health care needs. And in the interim, millions will die or be disabled, and economic development will be severely retarded. A paradigm shift is therefore needed. And the reason why the paradigm shift is needed is because we have inherited, and we, not only in Africa, but wherever, in the Caribbean, Latin America, and so on, here in the United States, the colonial system of healthcare, where the healthcare was based in hospitals, and it was for the elites. First, of course, it was for the colonial elites, and then it was for the local elites who administrated the colonial territories. So we have a top-down system. So, this is not working, as we can clearly see in terms of the Ebola epidemic that has devastated those 3 West African countries. So a paradigm shift is needed towards prevention, proper nutrition, health care, public health measures on primary care to be delivered in the rural areas where 75% of the population lives. And this obviously has to be part of an integrated healthcare system. It is both ethically and financially correct to promote health early rather than treat disease late. The greatest need, then, is for community and mid-level healthcare workers to be trained in the shortest period of time at the least expense. The Global Health Workforce Alliance suggested scaling up education and training curricula with a focus on the community, with prevention and primary care as the major objectives, with development partners using innovative means such as ICT to increase capacity. The World Health Organization also recommended training to task to create a cadre of health workers who receive specific training to gain competency in well-defined tasks that do not need the longer training of the degreed nurse or the MD. If these 2 measures are implemented, it should produce a rapid expansion of the number of qualified healthcare workers. I think this can be done through building health sciences centers, not through necessarily building more medical schools. I think that while there may not be enough medical schools, I think it's much, much better to build health science centers where you can have a 4-year program that will take kids out of high school. And in the first year, you can create a community health worker. You have the curriculum to do that. And the second year, you can produce a community health worker that is at a higher level, that can man your clinics in the communities, as opposed to the village healthcare worker who goes into the homes. By the third year, you can create your RNs and your midwives. You don't need necessarily degreed nurses. You need nurses who can treat patients and do adequate health care and deal with the reporting of ailments and different conditions. And by the 4th year, you can have clinical officers who then are, in some sense, like substitute doctors. They can man all of your clinics. You can have your clinical officers in the area of pediatrics, medicine, surgery, in my specialty. We're training healthcare workers to be able to do cesarean sections. And this is happening in many countries. In Mozambique, I know that's being done with acceptable mortality, similar to OBGYN people. You can do trachoma surgery, training clinical officers to do trachoma surgery. And you can do other things, simple things such as hernias, trauma surgery, suturing incisions, and so on. A lot of things can be done by people that have now been routinized in terms of medical care. And you don't need the BS degree after high school, and then the MD degree, and then the internship, or then the training program that takes another 3 or 4 years. You're talking about 4 and 4 plus more. Like you're talking 11 years, 12 years, and blah, blah, blah. Africa doesn't have that much time to really waste on that kind of investment, and it's not needed. What you need is the people who are going to be out there in the villages, and you saw that with the Ebola crisis. So my area of focus in terms of how I see the problem is that one needs to focus on community health as the primary ingredient of overhauling or developing the African health system. And I think that's where we should be as diasporans who want to participate and help Africa develop. Thank you.
Thank you very much. My mother was a nurse educator, but she started life out as a community health worker. And I remember as an 8-year-old carrying a bag, going from home to home. And I see myself now as a community health worker. So I think that word can apply to people with lots of doctorates and so on. It's how you connect a healthcare system to an actual community and manage that healthcare system appropriately. Dr. Arikana Chiombori is now going to speak about her experiences. She's a primary healthcare person, and she's a community health worker. I redefined you. I hope you don't mind. But one of her roles is to generate real feedback and contributions from the diaspora. As the previous speakers made the point, there are lots of us in this country who have come from Africa. And in part, we have to give back. Sometimes I feel some of us give back a lot more than others, and we hope that all of us give back as much as we can.
Good evening, everyone. My brother Mel, thank you for having us here, and thank you for putting together such a beautiful forum. My name is Arikana Chiombori. I'm a family physician born in Zimbabwe. I am an African diaspora, and like Dr. Hammond, I'm an African living in America. Last week, I was home in Zimbabwe, and I was having lunch with one of the elders who also happens to be an advisor to the president. And he was talking about Michael Jackson 15 years ago having gone to Zimbabwe, and he was visiting the Victoria Falls, and he ended up seeing this island while they were cruising down the Zambezi River. And Michael Jackson wanted to buy the island for $100 million. Well, the intelligent, educated, smart people of Zimbabwe in the cabinet, they met and they voted down the idea of Michael Jackson buying the island and developing it. They worried that if there should be problems with the United States, they didn't know what to do with the developments on the island. At that time, we had a 7th grade vice president. And when the vice president heard about what had happened in the cabinet, he wanted to ask the MPs, should we have problems with the United States? Are they going to come and bulldoze the hotels and take them to America? And there was silence. 15 years later, that island is still sitting. There's not a single hat on it. Michael Jackson had wanted to develop that. I'm saying this to say, as an African born and raised in Africa, educated partly in Africa, and I came here to go to college, worked here as a medical doctor, and also worked as a doctor in Zimbabwe. I'm sick and tired of the insanity and the lack of common sense that I see every day. 2 years ago, Ambassador Amina Ali appointed me to be the chair for the African Union African Diaspora Health Initiative. She tasked me with the responsibility of mobilizing African diaspora to not only look back, but to participate in the development of healthcare systems in Africa. Our first port of call was in Malawi. We were invited by President Banda to come and do a needs assessment. NGOs are wonderful people. Christian health organizations have done tremendous work, but I have my beef with them. Let's start with the NGOs. We found out in Malawi that 75% of the funding that was given to Malawi, DFID, various NGOs, went to the Christian health associations of Malawi. 25% went to the government to take care of the masses. The Christian health associations of Malawi, they have clinics, they have hospitals, but who ends up going to those clinics and hospitals? By and large, are the ones who can afford it. Now let me tell you something else. Pull back a little bit. Of the 75% that goes to the Christian health associations, those clinics that are run by the Christian health associations, their staff is paid by the government out of the remaining 25%. The majority of the people are going to the general hospitals, which are in horrible conditions. So I'm talking to the president. I said, Madam President, there's something wrong with this picture. I would like to come to Malawi and put up a clinic and a hospital, have the government pay for my staff, but when those who can afford to come and pay and they come in, they pay, I keep the money. I said, I like that situation. Can you get me in on this? I said, Madam President, why are you allowing this insanity to continue? She said, my sister, elections are won and lost if you try to tackle this issue. In Malawi, they are called CHAM, Christian Health Association of Malawi. If you go to Zimbabwe, it's CHAS. If you go to Ghana, it's CHAG. If you go to Sierra Leone, it's CHAS. I said, Madam President, I got a problem with this cha-cha-chas. She says, they are everywhere. They are all over Africa. They come in the name of religion. I was reminded they gave Shaka Zulu a mirror and put him on a swivel chair and asked him to give them some land. He said, point the land that you are giving us. And while he was pointing, they swung the swivel chair. Then they followed it with a Bible and said, let's pray. And while we had our eyes closed, they were stealing our minerals. And they took it a step further. They stole our soul. The legacy of colonialism, ignorance, is one of the biggest problems Africa has today. First, we have to understand that we got a problem. First, we have to understand that we don't understand it. But our colonial masters left us in such a state that even sometimes when we should challenge certain situations, we don't. We are afraid. Our leaders, you won't find me blaming an African leader, because you know what? Their hands are tied. If this president tries to challenge CHAM or one of these cha-cha-chas, they're everywhere in the communities. They will not win the next election. That is the reality for Africa. What has happened to common sense? These same cha-cha-chas, they have specialists coming to the different African countries. In Malawi, I'll use that as an example. We have registrars who are trained and ready to move forward and become specialists. But there are no training programs for them. Why aren't there training programs, Madam President? We only have 2 OBGYNs. There are 10 in the country, but the other 8 are employed by the cha-cha-chas. I said, Madam President, why can't we have a residency program here and the cha-cha-cha OBGYNs can be on staff and they can train? You don't have to be at this hospital. You can follow the doctor where they are. Or between the NGOs and the cha-cha-chas, it hasn't been discussed. What happened to common sense? What I saw as we toured the different African countries was insanity as defined by Albert Einstein. The NGOs, the cha-cha-chas are doing the same things over and over and over. I'm sick and tired of seeing research work. We know what the problem is. Let's go down to business. Capacity building, as Dr. Garvey talked about. You tell me why we have had all these NGOs and the cha-cha-chas going to Africa for decades. We talk about the problems of healthcare. Where is the first hospital that they have built? We need a training center for doctors so we can have everlasting solutions to Africa's healthcare issues. We need doctors to be trained. We need OBGYNs. We need surgeons. We need all kinds of specialists. They are pumping money with no results. I'll be very honest with you. I don't think they have any intentions of seeing change. Let's call a spade a spade. Picture this beautiful situation, a diaspora hospital with a big training center in Southern Africa, and another one in Kenya, and another one in Central Africa, and another one in West Africa. And let's give ourselves a 5-year period to train doctors. Let's pay specialists from all over the world, wherever you are, whatever you are making, when you come to this training center, we will pay you the same amount. So that way, we can train Africans to take care of themselves. Let's talk about sanitation and waste management. If we were to handle the issue of waste in Africa, we will cut the healthcare budget for most African countries in half. Trash. Let's buy trash. Buy trash, save lives, and make money. Simple. Where is the first waste management plan in Africa? We all talk about it. We pump money into malaria, into TB. Well, clean up. You no longer have malaria. Clean up. You no longer have cholera. But oh no, if we do that, that's a solution. And where all these NGOs gonna go? Africa, the insanity needs to stop, and common sense needs to come back home.
Amen.
Our last responder this afternoon is Mr. Raymond Dabney. Dr. Chiambore reminded us that Africa has had periods of colonialism, and we now have a period of neocolonialism under the guise of people coming to quote-unquote help us. And their help is mostly too little, and it actually makes them better and more renowned in the world. One of the things that I've learned in the few days that I've met Ray is that he is determined, he is brilliant, and he understands the nature of liberty. And those 3 things, I think, make him a very nice final commentator because of his understanding of liberty, true liberty, where who governs me is me, and who governs my actions It's also me. And that's what I think a lot of us are trying to do when we work in Africa, and to create people who are self-governing. So Ray, up to you.
Wow, thank you very much, Alan. I just have to say, wow. Today has definitely been an incredible day. It's been an eye-opener for me. I'm, very honored to be chosen as a part of the CFA team for this African Healthcare Development Initiatives. We had our first meeting last night, and I was very impressed, of course, at the scholars, the accomplishments, their positions of responsibilities, both in the African Development Mission in the CFA, and their well accomplished drug development experiences and education and scholars. My name is Raymond Christopher Dabney. I was introduced to the CFA through Dr. Roscoe Moore. Of course, Roscoe is the interim chairman of the CFA, and he's actually a leader in one of my company's scientific advisory board called Cannabis Science. We talked shortly after the U.S.-Africa Leaders Summit, which took place last August here in Washington, and it was in the context of the planning and the CFA's annual conference for a very special Ron H. Brown African Affairs series. I had just recently realized how important Ron Brown is to our whole situation. And, at that time, Roscoe had asked me to contribute to the CFA to support an earlier forum that they were organizing right here in the African Union Mission. And at the height of the Ebola crisis, and it was to educate the constituencies about the impact that the disease was having in Africa. I wasn't able to come at that time to attend the forum in person, but I read the report, and I was really moved by CFA's initiatives and its commitment to build public and private support for Africa and for the diaspora. Soon after, Roscoe had arranged for me to come to Washington and meet with Mel, who I'm very grateful to. We discussed my company, my foundation, Cannabis Science, and how we can address some of the pressing health issues, concerns in Africa. And Mel talked about the role the CFA played in advocating for the global response to HIV and AIDS pandemic, and its efforts that directly led to the President George W. Bush's $15 billion commitment to address the AIDS, HIV, and pandemic. Mel further shared his deep concerns and understanding about Africa and how African development issues and we were able to brainstorm about the opportunities and challenges that my company and foundation, that we might actually be able to make a real difference in Africa right now. We began with, I gave significant support for today to happen. And, being a part of all this is very important to me because it's my opportunity and it's my first step into this movement. The CFA efforts in the future for educating and strengthening the healthcare system and infrastructures in Africa were only solidified by me hearing each one of the speakers before myself. I have nowhere near the accomplishments on the scholarship educational levels and such, but I can assure you I have the business acumen to do so. I'm very, very proud to be a part of this very critically important initiative leading to the improvement of the African healthcare system. As for my part, I own several diverse international companies, both private companies and public companies. I'm involved in many different industries. I own companies in drug development. I own mining companies. I own high-tech companies. I own automobile companies. I own entertainment companies. I own medical device companies. I own many, many more. And I have offices and partners all over the world. We have operations in Canada, in the US, in Europe, in Spain, in London. And we're kind of all over the place. But I haven't gone into Africa yet. And, for whatever reason in my heart, I've been saving it for when I felt I was ready. And, in life, things come at a certain time. And, I'm blessed because my time has come. And instead of me just going there on my own with all my resources trying to figure it out, look at the team that I have behind me now. And, I thank Mel and I thank Roscoe for that. And, I just want to make it clear to everybody what our goals are. They brought me on board as a board member of this new initiative within the CFA. And we have 5 basic areas of focus. The first one is healthcare infrastructures, of course. Seems like everybody knows about the issues in Africa about that. You talk about drug development, you talk about medical devices, you talk about hospitals and healthcare systems. Second area is agriculture and food. You talk about infrastructure to eradicate poverty, teach people how to use the resources that they have for growing their own food, for example. You're talking about water safety procedures. You're talking about seasonal crop, meat eaters. You're talking about food safety preservation. And of course, you're talking about waste, which of course is very important, waste management. Third area, of course, that's very important is education. And education covers all of the areas that we're talking about. Because, we can send as many people in there that know everything there is to know. But if we don't teach the people that live there how to manage and how to operate and how to own and how to simply multiply through ownership and through motivation, which is all geared from or garnered from education, that's really the key behind it all. The fourth area, of course, is technology and communication. We have to set up systems or, I am a firm believer of not reinventing the wheel. So there's a lot of resources that I've learned about that are already there in Africa that can be utilized. And in technology, you're talking about satellites, you're talking about cell phones, you're talking about fiber optics, you're talking about landlines and devices, mechanical devices, so that people can communicate, like iPads, cell phones, and the rest of the devices. And the last area is political environments, having people aware of their environment using common sense that is a common problem around the world. And the environments and your political environments people need to be concerned about are regulatory jurisdictional processes. There are certain laws that we must abide by in order to accomplish our goals. There's processes to be able to change those laws and regulatory process so that we can accomplish those goals. And it's an understanding or giving the people of understanding how to do that. That's key. Media exposure programs. We have to educate them how to get the message out there in the media. So when you do something of great accomplishment, it gives other people incentive. It gives them that belief that, wow, we're all together and we can make this work. Job creation programs. I had phenomenal meeting yesterday with the board. Just the experiences that they told me, the time that they spent there. Job creation is one of the keys to Africa. And again, it comes back to education, educating the people that they can own what they do. And the last, of course, probably one of the most important, is investment programs. Teaching them that what they already own is worth something and how to multiply it, how to take those resources that they already have and turn it into something real, how to take the richest continent, as far as I'm concerned, as far as natural resources are concerned, and put it back into the people's pockets, put it back into the industry that will fuel the whole program. So on that note, in closing, I just want to thank everybody for giving me this opportunity. I know we have a major task ahead of us. I'm very heartened by my invitation from Mel to participate on the board of the CFA. I'm a Canadian citizen. I live in Vancouver, but I too am a member of the Worldwide African Diaspora, and I look forward to seeing everybody in Africa.
Thank you very much. We've had a cha-cha-cha, which is a little more elegant because it's a call and response in the old Baptist tradition. The call was in the first panel, the response was this panel. Mally is now going to accentuate the positive, as Ellington used to say, and open up a larger discussion. Thank you very much, everybody.
Stay with you guys. Stay with you. Let me have the mic. Okay. Basically, we're almost out of time, but I want to do a couple things before we close. I want to call on we got two of the ambassadors here. We had a third one, Ambassador Benin had to go, but I want to give Ambassador Stevens a chance to make a comment, and Ambassador from Mali a chance to make a comment. You can do it from there, or you can come up. Yeah.
Thank you very much, Mel, for the invitation. I want to promise you that I know it's a Friday. I know it's already 5 o'clock. I also have to rush to the World Bank. My minister is having a meeting there. So I promise you 2 minutes. I will just take.
We got 1 hour coming.
Yeah. There are some facts that need to be made known. Before Ebola, Sierra Leone was one of the fastest growing economies in the world. Additionally, we had massive infrastructural program going on in Sierra Leone during that same time. And this was done at the behest of our own budget, without loan or without any money from outside. Everything we were doing the correct things in Sierra Leone until the outbreak of Ebola. With the Ebola, we had massive death, and especially with critical professions. In the medical field, we lost doctors, very, very senior doctors, we lost clinicians, and then we lost nurses, hundreds of nurses. We lost all of them. We only had about 110 doctors for a population of 6 million. It's been stated here, and it's true, we have over 400 medical doctors in the United States alone, and many, many more in England. So what do we need? We need you to serve as advocates. We've done it before, and we can do it again. Our president is determined that we should be able to do it again. The Ebola figures have now gone way down. Today, it's 4 new cases that we had. It's a record that we are making. We believe that in a couple of months' time, Ebola will be behind us, and we'll be concentrating in the post-Ebola national recovery. So we need your help. We need help from the Constituency for Africa. We need help from all of you. And that help that we need is to be partners in helping us to go back where we were before. We are not coming cap in hand begging. We want to be partners. The Congress has appropriated more than $4.7 billion for Ebola alone. We want you, people of substance, people with a lot of courage, to make sure that that money is spent on helping the 3 countries, Sierra Leone, Guinea, and Liberia, to put us on our feet so that we can do things for ourselves as we used to do. Immediate needs: schools will reopen on the 30th of March. That's next year. We have immediate things we need, which we can contact the embassy if we can, because all of these infrastructure, school infrastructure, were decimated. We need blackboards, we need textbooks, we need exercise books. We need chairs, we need tables. Even if they are second-hand ones, we need them. So we need your help, and I thank you very much for giving me the opportunity.
And I want to call on the Ambassador of the Republic of Mali for a few comments. Mr. Ambassador.
Thank you. Thank you to the CFA to organize this meeting here, and thank you for inviting me. My name is Chena Koulibaly, and I am the ambassador of Mali. Mali's economy was not growing as fast as Sierra Leone's, but still the rate was positive, because in 2011 we had rate of 5%. But then in 2012 occurred a rebellion in the north of Mali, and the country was separated in two. The 2/3 of the country was occupied by the Tuareg rebels. And you know how things have been going on. Thanks to the help of France and the whole international community, while we're having peace talks now going on in Algiers. But then, so in the north, all the health infrastructures were destroyed by the jihadists. And so the economy was rather going bad in 2012, 2013. But in 2013, we have elected a new president who has a great leadership. As a matter of fact, when we had an Ebola outbreak in Mali, the president committed himself very, very much. And well, thanks to his efforts and thanks to the help of the international community, we had only 7 cases in Mali, of which 5 deaths, and 2 people have recovered. But what the Ebola outbreak shows us is that our health system is very, very, very weak, very weak. So it's organized into a pyramid from the village level to the national level. We have national level, national hospitals, we have regional hospitals, we have center references in the circles. So we have a well-organized system, but what is mostly lacking is the funding. So that is the help we need from you. Thank you.
Okay, I'm going to call on Sam, who's a member of he's actually the parliamentarian for our new African Infrastructure Healthcare Committee. And he's going to give us a 2-minute summary. So, Sam.
Thank you, Mayor. I'll keep it to 2 minutes. Today has been a historic occasion, and we've had lots of discussions, which I'm going to summarize under 4 points. First of all, we had troubling concerns from our panelists and our respondents, as well as our keynote speaker. That was a number of things like the infrastructure problems, doing the same things over and over again, expecting to find the same, to get a better solution, but not getting it. The second set of comments really brought some rays of hope in terms of what the solutions might be. And then the third set of comments were on the way forward. Most of the speakers did conclude with some ways forward. And in this regard, I would just like to describe my understanding of what the CFA might do. It seems like CFA has been given a charge to lead on the solutions. And the first one is, we know there is insanity. It needs to bring common sense back. The second one is, you need to bring stakeholders to generate solutions that engage Africans within their communities and deliver solutions that work for the people right now. And the third one is to engage stakeholders into a paradigm shift in terms of funding and training programs. The CFA has established a committee on health infrastructure in Africa. I am the parliamentarian for that committee. That committee has several standing subcommittees, and these include education, agriculture and food security and nutrition, politics and policy, technology and communication, as well as healthcare infrastructure. So these standing committees are there for you to come and contribute, and I think that if we do that, we're going to come back and receive a more pleasant report next time. Thank you very much.
Thank you. I now want to call on the representative from the African Union. I want to really, again, thank the African Union for hosting us here today. It's great to be part of Africa, and I think this is exactly what this building is to become for the future of Africa. It's the center place for Africa, really in the United States, but certainly here in Washington. So, Serafina.
Thank you, Mayor. Thank you. I'm going just to thank you all on behalf of Her Excellency Ambassador Ari, and to let you know that you are always welcome to Africa House, and really to thank all the speakers and to thank you for your ideas, for sharing with us your experiences and your strategies. And as I discussed with Mayor earlier, we need to really to build on this important forum. And I will just pick one speaker, and this is my sister, Dr. Chihombori. I know that after listening to her, you now, we just ask you to respond to her call, and which is, of course, the call of the African Union, just to come with her and help us build a diaspora center for training, as she requested, and she's really our voice, and we just want to thank you all. We just want to thank Your Excellencies for making time to come here, and thank you for what you did. Thank you very much.
I now want to call on Dr. Moore for his closing thoughts.
Closing thoughts.
Please.
Yes. Again, thanks everybody for coming out. I just want to say one thing about Sam Guluteye, who came up here a second ago. Sam is a physician at the National Cancer Institute. So thank you, Sam, for participating. This is not a pan thing. It's going to happen this time, and it's not going to happen again. Attempting to institutionalize this. That's why we have a committee of about 15 people. Again, as Sam pointed out, divided in certain areas. And if something fails between now and the Ron Brown series, we'll take it to the Ron Brown series. The thing is to get this institutionalized throughout what CFA does and what the African diaspora can do. Thank you very much.
And in closing, I just want to say a couple things that we're already thinking about. We're going to have a meeting with the African Diplomatic Corps to talk about these issues. We're talking to Congresswoman Karen Bass, and Greg Simpkins is helping with that. We want to do a hearing on Capitol Hill on the issue of healthcare infrastructure in Africa this year. We're planning the town hall meeting on Africa. CFA signature Ron Brown series will be on the healthcare infrastructure in Africa. We're talking about going to Africa and meeting with the African ministers of health. We want to be a support base for them. We're not there to lecture them. Many of them need help. They need technical assistance. They need advice. And if the diaspora can't provide, there's one area that the diaspora can really have an impact in. The most knowledgeable people I know, there are 50,000 Nigerian doctors in North America, 50,000. And we're not talking about the general hospital doctors. We're talking about the best brain surgeons. We're talking about the heart specialists. They're so busy saving white people over here. We're going to try to turn a little bit around so we can help save Africa. So those are just a snapshot of what we're going to be trying to do this coming year. I mean, we're already rolling. The committee meeting met yesterday. It was awesome. Awesome. The talent is just awesome. And we know we're just scratching the surface, but we think we're on the right track. We think we're on the right train. We just need to put more gas, more fuel in the tank, and go faster. I think I should be in a movie, Jeffrey. So I want to really just close by thanking you all for coming. I'm hoping Jeffrey will stick around for a few minutes to take a few pictures with some of you. He's a great guy, and I want to thank you all for coming and for staying to the last minute. You are the true testament of the constituency for Africa. Thank you very much.